Hi, everybody. My name is Kotiah. I work at the Mercy Medical Center in Baltimore, and I have an interest in neuroendocrine tumors, and I'm pleased to be able to talk to you guys today about managing neuroendocrine tumor symptoms and treatment side effects. So, we're going to cover a lot of material in a very short amount of time, and I'm going to try to highlight some points so that it doesn't get too overwhelming. And of course, if there's ever any questions afterwards, I'm happy to discuss, or, even over email or just, in the question and answer session. So, I put this slide up just to remind everybody that there's a lot of terminology that is around neuroendocrine tumors, and it can be very confusing. We usually say neuroendocrine tumors when we're referring to slower growing tumors, and neuroendocrine carcinomas when we're referring to faster growing tumors. Carcinoid is a term for a neuroendocrine tumor that is slow growing and can also produce hormones like carcinoid syndrome and serotonin production. And then neuroendocrine neoplasms just is a catchphrase for all neuroendocrine tumors, the fast and the slow growing ones. And then functional neuroendocrine tumors are the neuroendocrine tumors that produce hormones. And that's about, 20% of the cases. It's usually non-functional, that what we deal with on a day-to-day basis. But when somebody has hormone production from their tumor, it's very dramatic, and it definitely affects their quality of life. And it's most of the time fairly obvious to us that that person's having hormone production. So we classify neuroendocrine tumors in different ways. We say pancreatic versus non-pancreatic just because there's some subtle differences in how we treat pancreas versus non-pancreatic, although those differences seem to be fading over time, but that was the classical way that we separated neuroendocrine tumors. And then functional versus non-functional, is this something that is this a tumor that's making hormones? And then gradient differentiation, and we rely highly on the pathologist to give us this information when they give us your pathology report. Is it something that's slow growing? Is it something that's fast growing? Does it look more disorganized under the microscope? Does it look more like a normal hormone producing cell? So all that information comes, and we just have to be careful, because if somebody has presented with disease in different places, like it started in the small bowel, ended up in the liver, when you get a sample of the tumor, you're only getting a small representation. So really what matters to us when we're talking about slow growing and fast growing is what is happening to your scans over time to truly get a good sense of how slow or fast growing it is. So generally speaking, fast-growing neuroendocrine tumors and non-functional neuroendocrine tumors, the reason that we find out that they're there is it causes some symptom by growing and putting pressure on things. There are people who the cancer hasn't spread yet, and they get a CAT scan for some other reason, and they're found to have this lymph node mass in their abdomen that's kind of calcified, and then they say, oh, this looks like a neuroendocrine tumor of the small bowel. So there are people who have no symptoms. Then there are people who end up with bowel obstruction from a small bowel neuroendocrine tumor. There are people who bleed because there's a mass in the pancreatic tail, and it's causing these blood vessels to pop out to the surface, and they can cough up blood. So, these are sort of dramatic examples. People who make too much hormones, it depends on which hormone they're making. And again, the classic one is when you're making too much serotonin from a small bowel neuroendocrine tumor that's spread to your liver, and then the patients can have horrible dry flushing, diarrhea that wakes them up at night. So it depends on the hormone. If you're making too much insulin, then your blood sugar can drop, and you can get symptoms from that. So depending on the site and whether or not it's making hormones, you'll have different presentations. The head of the pancreas, whether it's the regular pancreatic adenocarcinoma that we deal with 95% of the time, or an neuroendocrine one, if it grows and it presses on the bile ducts, people will turn yellow, and that's how they know that there's something going on. And then again, if it's in the bowels, the gut might not be emptying well. There can be a lot of abdominal pain because there's not good blood supply going to the bowel because the tumor is kind of choking the blood supply. And then for patients who have cancer spread, if it's in the bones, you can have bone pain. If lots of serotonin is affecting the heart, then you can have problems with your heart valves and shortness of breath. And the way we figure that out is we do an echocardiogram, ultrasound of your heart. And then, of course, if there's a lot of pain, people sometimes are afraid to eat, and that leads to a lot of weight loss, not because they're not eating enough calories. Sometimes you eat a normal amount of calories and you're still losing weight because the cancer is taking in and sucking up your calories. So we always watch for weight loss, whether it's being caused by not eating well or just happening for no reason. These are signs that we look for. And then ultimately what people will succumb to if their liver gets taken over by neuroendocrine tumors is liver failure. And the signs of liver failure are yellowing of the eyes, pain in the right upper part of your abdomen. So these are things that we always keep an eye on the scans, and we keep an eye on your symptoms to make sure that that's not happening, because that's our biggest concern when somebody has spread of their neuroendocrine tumor usually. So carcinoid syndrome, this is like a very nifty little diagram where they're talking about how serotonin gets made. It starts with this amino acid that called tryptophan, and the neuroendocrine tumor cell uses it to make a lot of serotonin. And then if it's made by your small bowel, your liver breaks it down. Once the cancer spreads to the liver starts making serotonin. It's hard to break it down. It gets dumped straight into the bloodstream. And then the way that you can tell is you do 5-HIA, which is the breakdown product of serotonin. So you measure 5-HIA levels either in the urine or the blood. We have both available. You just have to be careful what you're eating or whether or not you're able to fast to get accurate results. And if you see a lot of 5-HIAA in the blood or the urine, and the person's having flushing, diarrhea, shortness of breath, palpitations, then you're like, well, this person sounds like they're having carcinoid syndrome because you put those two things together. And really bad, rare complications of that are when the heart gets damaged, the valves get damaged, scar tissue builds up around the small bowel, and you can have like a carcinoid crisis where the blood pressure can drop and it can cause depression and neuropsychological disorders. So we look for like these rare complications, but we usually deal with flushing and diarrhea. So the next slide gives you the frequency of how often things happen, and 94% of patients will get the dry flushing. And sometimes they can feel their face turning hot. Sometimes they don't even know. They're sitting down talking, and then you can just see them turning red in front of you. And then diarrhea is the second highest presenting symptom, and then much less is heart valvular problems. I will say that over the course of time, that we're becoming more aware of neuroendocrine tumors, and it's getting shorter to the time of diagnosing patients with neuroendocrine tumors. It's not as common to see heart damage and valve damage because we're getting people on medication to control the serotonin production. And if somebody's serotonin production is still high after you've put them on medication, because it can still happen that it brings it down but isn't corrected completely, then you always want to do an ultrasound of their heart once a year just to make sure that you are keeping an eye on their heart valves. So these are the 5 E's that trigger carcinoid syndrome. Epinephrine, which is a drug that we use in the hospital, and that can bring on the symptoms. Certain foods can bring on the symptoms, like pineapples. Having stress can bring on the symptoms. Drinking alcohol can make your symptoms worse, and exercise can make your serotonin levels go up. So there are things that trigger carcinoid syndrome that patients are aware of, just because as they go through their life, they realize that certain things that they do make their symptoms worse, and they can try to modify what they're doing to make their lives more comfortable. And the medications can help also. What about pancreatic neuroendocrine tumors? Well, again, it depends on which hormone. So just remember that the majority of patients with neuroendocrine tumors don't have hormone production. So for the ones that do, depending on which hormone-producing cell is affected in the pancreas, you're going to have different symptoms. So again, if you have insulinoma, you have high insulin levels that you can measure in the blood, and patients have really bad blood sugar dropping, and they get sweating, they can go into a coma, they get dizzy. If it's a gastrin hormone production, then you end up having very high acid levels in your stomach and ulcers in the stomach, bleeding. Sometimes the stomach can kind of perforate. So these things are very dramatic presentation. Too much glucagon. Glucagon is the opposite of insulin. You're using your sugar for energy. And so then when you have too much glucagon, you end up having diabetes, and you can get diarrhea, you can get inflammation around your tongue. So it just depends which hormone it is. So what about the stomach neuroendocrine tumors, the gastric neuroendocrine tumors? Well, there's actually 4 different types currently, but the 3 types that we deal with, the one that's more aggressive, and not necessarily like it's gonna definitely be more aggressive, but the one that we get concerned about more is type 3, where you actually have normal gastrin levels, but the hormone gastrin, is elevated in type 1 and type 2. And with type 2, you see a lot of stomach ulcers. With type 1, you don't always know that you have it, but when they look inside the stomach, there's multiple polyps. And so you can kind of tell with the acid output, it's high for type 2, it's low in type 1. And usually the type 1 and type 2 tend to do better. But, the high gastrin can cause high acid production. So how do we treat the hormone production? We use somatostatin receptors. The somatostatin is a hormone that, generally speaking, under normal circumstances, controls production of other hormones. So most neuroendocrine tumor cells have overexpression of somatostatin receptor. So a normal hormone-producing cell might have a couple of receptors, but neuroendocrine tumors have overexpression. So you can see in pancreas and midgut, it's quite elevated, especially somatostatin receptor 2. So we use that knowledge in a lot of different ways to help people treat their neuroendocrine tumor. So one of them is to make a long-acting form of somatostatin. So somatostatin is a hormone that usually lasts about 1 to 2 minutes. A half-life is actually 3 minutes in the bloodstream. So it's very quick acting, quick on, quick off. But we've made drugs like octreotide and lanreotide, which are drugs that last about 28 days, and you get an injection, and usually in the buttock area. The octreotide is usually given intramuscularly. The lanreotide is a deep subcutaneous injection, and we're trying to mimic the somatostatin. And so the studies have shown that the use of these drugs can slow down the production of hormones from neuroendocrine tumors and can sometimes slow down the growth of these tumors. So we use them for both advantages, to try to control tumor growth and to try to prevent hormones from being made so patients can have better quality of life. Okay, so there are side effects of somatostatin analogs, and you should be aware of them, especially if you're being treated with these drugs. And so when I think of somatostatin analogs, I think of it as hormonal manipulation versus when I give chemotherapy. So I tend to find it easier to give somatostatin analogs than chemotherapy, but every once in a while somebody will have a side effect or an intolerance, and you just need to be aware what the side effects could be. So injection site pain is a common thing. You can have bloating, you can have diarrhea from the drug. So then it becomes confusing when people have diarrhea. Is it from the medication? Is it from their tumor, their hormone production? So we'll talk about that in a little bit. You can have a small risk of gallstones. We don't necessarily remove the gallbladder if we're not going in for surgery otherwise, but if patients have surgery for neuroendocrine tumors, it is a general routine practice that if the thought that they're going to need somatostatin analogs and you don't need your gallbladder, they can remove your gallbladder at surgery. Your blood sugar can usually rise on these drugs. You can have floating stools. You can have abdominal cramps. You can have headaches and dizziness. You have to check your thyroid function. Sometimes you check zinc levels. And you have to be careful with patients who are on drugs like beta blockers, like metoprolol, because it can decrease the heart rate. So these are things that we warn patients about. Zermelo is a tablet that you take 3 times a day, and it blocks this enzyme called tryptophan hydroxylase so that you're not able to make as much serotonin. So that's a drug that's been approved to help control syndrome, and it works better with diarrhea control and doesn't work as well with the flushing, but it can help the flushing to some degree. But that's another drug that we have in our arsenal to try to help control diarrhea from carcinoid syndrome. It's not meant to control tumor growth at this time. We don't have data for that, but we do know that it helps with the diarrhea from the carcinoid syndrome. And not everybody, but most patients get some relief from this drug. So what you need to know is that it can cause nausea, it can cause headaches, it can cause depression. You have to watch the liver enzymes on this drug because it can cause one of the liver enzymes to increase, swelling in your legs, some decreased appetite. Patients can get a lot of gas. I get that complaint a lot in general, whether it's with the lanreotide, octreotide drugs, or with the Zermelo. Patients complain about gas buildup. And then there's a small risk of fever. I haven't seen that too much, but that's another potential side effect. So what about diarrhea? Diarrhea can be very complicated. So it's very important that if somebody has carcinoid syndrome and they're having worsening of their diarrhea, you check their serotonin levels. Are they going up? Are they coming down? If the serotonin levels are lower and the diarrhea is getting worse, then you have to think about, is it the drug? Is the lanreotide or the octreotide causing the pancreatic enzymes not to be produced, and then the stools are floating? Because that can happen as a side effect from that drug. Are you not absorbing bile salts? Is it happening because surgery and your bowels have been shortened and now things go through much more quickly? So it can be complicated, and some information can help you figure that out so that you can help manage some of your symptoms so you can have better quality of life. So targeted drugs are drugs that we use. They're not really chemotherapy. They're not trying to kill whatever's growing fast, but they're going after specific protein inside the cancer cells. And those proteins are usually being used to help the cancer cell grow. So like proteins that increase blood supply to the tumor is a very common target for neuroendocrine tumors. And we've developed different drugs for that. And those drugs can be used across a wide variety of cancers because a lot of cancers are very vascular. They use the blood supply to try to feed the cancer. So everolimus and Sutent are 2 such drugs where we're trying to disrupt the blood vessel growth of the tumor. And these drugs are really used for stabilizing the cancers. They're not great shrinkage drugs. It's hard to shrink things that grow slowly. And again, these drugs are only for slow-growing neuroendocrine tumors, not for fast-growing neuroendocrine tumors. A lot of the treatments that we've been talking about so far are for slow-growing tumors, the somatostatin analog, or Zermelo, and these 2 drugs, the everolimus and Sutent. So you have to be careful with the everolimus because it impacts your lymphocytes, which are the cells that help you fight off viruses and bacteria. So there is some increased risk of infection on the drug. You can not heal as well, so be careful around surgeries. Mouth sores can happen, and there's a way to prevent that. There's a steroid rinse that we use that works pretty well. And you can have some lowering of your blood counts and some fatigue. The Sutent is mainly approved for pancreas neuroendocrine tumor, so the 2 drugs can both be used for pancreas. But you have to watch your blood pressure on that drug, and you have to be careful about cracking of the skin and the hands and the feet. And it can cause protein to spill in your urine. So we watch all of these things as well as watching your blood counts and your liver enzymes. So most of the side effects of these targeted drugs can be managed by interrupting the dose, sometimes lowering the dose. Sometimes despite those modifications, patients still can't tolerate. And in that case, sometimes we do have to stop and not continue forward with that drug. But for the most part, we can manage it with dose reduction and trying to interrupt the treatment. So another class of treatment that we have that was approved a few years ago is a targeted radiation to the cancer cells, something called PRRT. And what we do is we take advantage of the fact that there's overexpression of these somatostatin receptors, and we attach a radiation emitter to the somatostatin drug, and then it goes and finds the cancer cell, binds to the receptor, the drug gets the radiation inside the cancer cell, and then the radiation releases in a short burst and travels only about 1 to 2 millimeters, and it is able to control cancer growth and stop the cancer from growing for a lot of the patients. So again, this is mainly approved for slow-growing neuroendocrine tumors, not fast-growing neuroendocrine tumors. And you do have to be careful that the kidneys have to clear the radiation. So there's a risk of kidney damage. So we give an amino acid infusion to protect the kidneys. It can cause nausea, the amino acid infusion, not the actual radiation itself. And so we pre-medicate with nausea medications, although they've reformulated the amino acid infusion. It's much better now. It doesn't make people as nauseated. You can have lowering of your blood counts after PRRT. So we watch your blood work closely, and as well as your liver enzymes. And the inflammation can be managed by steroids depending on how bad it is. We can give steroids around it to prevent that complication. But we usually check your liver enzymes, make sure you're not having abdominal pain, looking for nausea, watch your blood counts, and then monitor your kidneys. So chemotherapy can work for slow and fast-growing neuroendocrine tumors. It tends to work more effectively for fast-growing tumors, but it's trying to damage the DNA of the cancer cell or preventing from pulling apart. So different chemotherapies work on different parts of the cancer cell to try to prevent division and growth. So generally speaking, the fatigue, low blood counts, and hair loss are common side effects of chemotherapy. So it doesn't happen as much with zolbetuximab, but it can happen with other chemotherapy agents. Nausea is usually managed by nausea medication. Diarrhea, we use Imodium lomotil. And if it's worse than that, then we have other drugs in our arsenal. We always have patients monitor for infection because that's one life-threatening thing that can happen on treatment, depending on how strong the chemotherapy is. And usually your oncologist will explain to you about when the white count is expected to drop, when it's expected to recover, when you should be more careful about infection, not eating out at restaurants, especially salads and things that you don't know have been rinsed properly for bacteria, not having fresh flowers with fertilizer next to you when your white count is low. So your team should always do a full chemotherapy consent and explain to you all the potential risks. Certainly drugs like cisplatin and carboplatin can affect the hearing, can affect the kidneys, cisplatin especially. And the cisplatin can cause bad nausea. So we usually pre-medicate before these infusions to prevent a lot of these side effects to make it more tolerable, because we're trying to control poisoning. We're trying to kill the cancer cells but not affect the normal cells too much, but sometimes there's a little bit of a trade-off. And then, of course, the Temodar tablets that people can take for their neuroendocrine tumor can cause bad nausea. So I always tell the patients, half hour before you take that pill, always make sure that you take your nausea medicine. There's a couple people who didn't listen and had terrible nausea and vomiting. So make sure that you follow instructions to try to avoid toxicity from chemotherapy. Liver-directed therapy is when the interventional radiologist uses the blood supply to the liver, the hepatic artery, to try to either feed chemotherapy to that part of the liver or try to cut off the blood supply to that part of the liver so the tumor doesn't thrive and grow. And sometimes you can feed radiation directly to the liver using the artery supply. So there can be bleeding at the puncture site where they're trying to access the artery. You can have pain, inflammation of your liver. You can get infection or abscesses in your liver. You can get injury to the bile ducts. Thank God these are not high risk things, otherwise we wouldn't be doing this on a regular basis. But these are complications that can potentially happen. And a lot of the centers can use some steroids, some antibiotics, and they watch your blood work after they do the procedure to make sure that they're monitoring you for any complications and trying to be ahead of things so that the patients end up getting through it in the safest way possible. But for anything that is done with procedure-wise, it should always be a full disclosure, risks, benefits, side effects, so that the patients are aware of what could potentially happen. Immunotherapy is a way to get your white blood cells to kill your cancer cells, to put it simply. And not every neuroendocrine tumor responds to immunotherapy. We haven't had great responses to immunotherapy, but it is approved for stage 4 small cell lung cancer, which is a very fast-growing neuroendocrine tumor. And there can be a lot of autoimmune problems that happen. So the white blood cells can then attack your normal cells and inflame them. So there can be liver inflammation, lung inflammation. So people can get coughing and shortness of breath. The thyroid can get inflamed and you have to give thyroid replacement. You can have terrible diarrhea from colon inflammation. You can have a rash, and usually steroids turn off a lot of these side effects. But it's always important that we monitor blood work and we monitor symptoms when patients are on immunotherapy to try to prevent these complications. Overall, it's fairly well tolerated. It's, again, intravenous treatment that we give every 3, 4, 6 weeks, depending on which drug that you're using. So that's sort of a nuts and bolts, very quick review of treatments that we offer and the side effects from these treatments. And so just remember that the majority of neuroendocrine tumors do not produce hormones, and they can just cause symptoms by growing and pressing on things. And that we rely on somatostatin drugs like lanreotide and octreotide to control hormone production from tumors. And that treatments can have varied side effects, and the side effects can be mild and tolerable, or they can be severe. And communication with your medical team is crucial. I always tell the patients, don't wait weeks before you tell me something. If it's an uncomfortable side effect right away, if it's bothering you or it's preventing you from eating or drinking or hydrating, you need to tell me. If it's something that's nagging and persistent and it's not going away, and whatever medication I've given is not controlling the symptom, whether it's nausea or diarrhea, please let me know so that you don't end up getting dehydrated and you don't end up hospitalized. So for the most part, if we're really aggressive about symptom management, people can avoid being hospitalized, but there should be a good two-way communication so that we can avoid that. Sometimes it's not avoidable, but for the most part, it has been. So hopefully you guys have found this helpful, and I'm happy to answer any questions. Thank you very much.